So, retinal detachment. So, what is retinal detachment? Retinal detachment is how are we going to explain it? Occurs when there is separation of retinal neurosensory layer from the underlying retinal pigment epithelium and choroid. So, what's the reason behind retinal detachment? So, retinal detachment is highly associated with posterior vitreous detachment, yeah, posterior vitreous PVD. So it usually occurs after intraocular procedures, and when there is posterior vitreous detachment, this the cursor is pointing towards the vitreous humor. When there is detachment of the vitreous is actually really adherent to the retina. The outermost layer of the retina, which is the neurosensory layer, and when the vitreous gets stuck on, it also detaches the retina as well along with it. So these two conditions go hand in hand with one another, and they are usually the most commonly a complication of intraocular surgery. So it can be acute, it can be delayed, but it usually starts at the periphery, as you can appreciate in the image as well. And since it starts at the periphery, so the initial loss of vision is from the peripheral fields. And then gradually, as the detachment progresses centrally, you also get a loss of vision centrally. So in onset of what is going to happen, let's discuss that as well. During the initial detachment, depolarization of the retinal neurosensory layer is perceived by the person as photopsia, flashing lights. So when the detachment occurs, the person perceives flashing lights, and after that, temporal fields get defective, so peripheral vision gets affected. And that peripheral vision, and since it is associated with posterior vitreous detachment, so debris that is present in the vitreous humor is also perceived as webs or floaters. So during the process, photopsia during the detachment, and loss of peripheral vision, and after that, the debris in the vitreous humor is gonna cause perception of floaters. So these are the symptoms that the patient is going to present with. The patient is going to say, I have difficulty seeing peripheral fields, and I can see webs in my vision, I can see floaters. And when this started happening, the patient is also going to tell you that he saw flashing of lights. Now let's also move towards what are the most common causes. As I told you, intraocular surgery, and after that, myopia. So how does myopia cause retinal detachment? Let me draw it right here. So this is what happens in myopia. As you guys know, this is the cornea and this is the rest of the eye. In myopia, the light is focused at in front of the retina. And what is the reason of the light being focused in front of the retina? The reason is either the axial length of the eyeball is too long, or the convergence power of the cornea due to its congenital shape that is really high. So the light gets focused in front of the retina. So in high myopia that is 6, 7, or 8, what usually happens, if the reason behind is a greater axial length, that makes the what I must say, that makes the integrity of the structure really poor. And because of the poor structural integrity of the retina and the vitreous humor, the process of detachment might not occur. But if it wants to occur, this specific axial length of the eye being really high can really facilitate the process of retinal detachment. So the high axial length causes the detachment to occur relatively with ease when you compare that with the normal person. The first one, the biggest reason, is intraocular surgery, and the second one is high myopia. So these two are the main ones. Ocular trauma, obviously, if there's a trauma, then that can, the shearing forces can result in retinal detachment in that case. So you can appreciate the retinal detachment really well in this image. As you can see, This part of the retina has been detached, and as you can also appreciate it is starting in the periphery, and then it has gradually progressed to the center, but it starts at the periphery, and the appearance is wrinkled, as you can appreciate the wrinkling here, and you can also see that the appearance is relatively grayish. The detached retina appears relatively gray to the undetached retina. So this is a really cool image that I would really like that you keep in mind. Now let's just also give a rapid read risk factors: intraocular surgery, myopia, ocular trauma. Retinal detachment is most commonly caused by PVD, as I told you guys. It is a gel-like vitreous which is usually strongly attached to the retina. Separates from the retina. It can cause mechanical depolarization within the neurosensory layer. It can dug onto the retina and push the outermost neurosensory layer along with it. Patients experience depolarization, the initial detachment as flashes of light photopsia. After that, the vitreous debris is experienced as floaters, dark spots, or webs. PVD can also tear the retina. If the fluid seeps behind the tear, retinal detachment occurs. Okay, it begins in the periphery, causing peripheral visual field defects before progressing centrally. Examination shows sluggish pupil, gray elevated retina that may have wrinkled appearance, and the only treatment here is retinoplexy, that you'll have to surgically fix the retina back to its original location. So this covers everything. Age related macular degeneration, this is one of the problems that has everything in the name. Age related, it's gonna occur in people who are 50 years plus because it is age related. Macula, what is macula? Macula is the central most part of the retina. So it's the central part of the retina, and the age-related degeneration results in degradation of the retinal pigment epithelium in that area, as well as choriocapillaries and everything else. So it's basically just the degeneration of macula. And since the macula is the central part, so what part of the vision is going to be affected first? You can ask yourself, and the answer is really simple. That is central vision. Peripheral vision would be intact, and the initially you would get the central vision would be affected initially, and the patient population would be that of 50 years plus. And the loss of vision is usually bilateral because it is age related, and the highest yield point here is that it's gonna be bilateral loss of central vision, that and the peripheral vision would be preserved. So one more thing that might be asked is that they give you a patient who initially complained of loss of central vision, and he was 60 years of age, but then eventually also had having trouble with peripheral vision. So in a case such like that, when you examine the eye with the ophthalmoscope, you see that the patient has also developed a cataract in addition to age-related macular degeneration. So the cataract is now affecting the peripheral vision, and the central vision had already been affected by the AMG. That is why the patient now had a loss of both the central and peripheral vision. In this case, you just do a intraocular lens replacement, and the patient then regains the peripheral vision. So I just wanted to mention that as well, because in some cases you might get confused because the patient presents with an initial loss of central vision that has progressed now to peripheral. So the etiology behind the central loss of central and the peripheral vision are different in such cases. CMV retinitis. CMV, as you know, it's a CMV causes a lot of AIDS-related illnesses. You guys also know about CMV colitis. Just like that, we also have CMV retinitis. The highest yield thing about that, how you're gonna identify, is that an AIDS patient with a low CD4 count, most probably less than 100, presenting you with floaters, blurred vision. That's how you identify CMV retinitis. That's not how you identify it, that's how you get a direction that points towards it. How to identify it and make sure that it's CMV retinitis, not HIV retinopathy. There's also a thing termed as HIV retinopathy. You look at the cursor here, I'm pointing towards HIV retinopathy. So yeah, AIDS related patient can have both of these, but how you're going to differentiate it, Simple. You're gonna do a fundoscopic examination, and the fundoscopic examination is gonna show you yellow, white, fluffy hemorrhagic lesions around the retinal, just adjacent to following the retinal vessels. Let me show you a diagram. So here it is. So you get a AIDS patient with preferably with a low CD4 count of 100 that complains of new onset floaters. You do a fundoscopic examination, and then you see that all the retina that then you see white, fluffy white lesions, as well as hemorrhagic lesions surrounding the retinal vessels, just following the retinal vessels. Then you know it's CMV retinitis. So here's a image also showing that these are retinal vessels, these are the white fluffy lesions, and these are the black ones are pointing towards the hemorrhagic lesions. So this is CMV retinitis, and we're gonna also give it a read retinitis, the most common end organ manifestation of CMV in patients with advanced age, CD4 count less than 100, generally presents with blurred vision, floaters, photopsia. Fundoscopic examination is diagnostic. As I told you guys, yellow white fluffy hemorrhagic lesions adjacent to the retinal vessels and fovea. Patients with CMV retinitis are usually treated with oral antivirals. Yeah, obviously it's CMV, so it's a virus. We're gonna treat with Valgan, cyclovir. The question is, why can't we use the topical ones? We can't use the topical ones because the problem is in the retina. It's a deeper eye structure. It's not the cornea. It's not the iris. It's not the conjunctiva. Those are superficial. You can use topical in that case, but it's a deeper. So you're gonna use oral antivirals. Lesions near to the fovea or optic nerve also require concomitant intravitreal injections to reduce risk of blindness and retinal detachment due to retinal scarring. So retinal scarring is also a really big phenomena. Let me show you that. So here is an example. This is an example of toxoplasmic chorioretinitis. So I just wanted to mention out the scarring here. So this is the active lesion of toxoplasmosis, and the one you see here that is blackened, this is scarring. So repeated infections can result in retinal scarring, and the retinal scarring then gets adherent to the adjacent posterior vitreous humor. And as I told you about, these two are really connected with one another. When the scarring occurs and the fibrous tissue contracts, it can lead to tugging on the retina and the detachment from the posterior the neurosensory retinal layer then detaches from the pigment layer, and you get that wrinkled appearance of the retina that happens in detachment. We just talked about it. So scarring can lead to retinal detachment. I just wanted to explain the mechanism as well as show you guys how the scarring actually looks like. This the cursor is pointing towards these black areas. This is where the infection previously happened, and now this is a scar tissue, and this white fluffy region, this is active inflammation and active infection. As you can see in this picture, this is also active infection because this is white and fluffy, and when the scar happens, it turns really blackish or dark grayish. So it's really easy to identify the scar. HIV retinopathy. So we're also going to discuss all the differential diagnosis that they usually give when it comes to CMV retinitis. When they would present a case of CMV retinitis, the options or might also include HIV retinopathy, toxoplasmic chorioretinitis, or syphilitic chorioretinitis. How are you going to differentiate between all of these and choose CMV retinitis as the same answer? The most confusing one is the HIV retinopathy, because CMV retinitis occurs in patients who have advanced AIDS and a CD4 count less than 100. So yeah, the presence of HIV in both cases, that can be confusing, but the difference between CMV retinitis and HIV retinopathy is that first of all, cotton wool retinal lesions that are rarely hemorrhagic and tend to resolve over weeks to months. So HIV retinopathy is a really mild disease compared to CMV retinitis. That is how you are gonna be able to differentiate between them. And when it comes to CMV retinitis, you are gonna have a CD4 count less than 100, blurred vision, floaters. This blurred vision and floaters is not present in HIV retinopathy. So the presentation is relatively really mild. That is how you'll be able to differentiate. And if you get a fundoscopic examination as well, that's going to make everything really clear, because you would not be able to find any hemorrhagic lesions. You would not be able to find cotton wool lesions that surround the retinal vessels. So the distribution of the lesion would really make it really easy for you. The second one is toxoplasmic chorioretinitis. Uh, the biggest difference between CMV retinitis and toxoplasmic chorioretinitis is the vascular distribution when it comes to CMV retinitis, and non-vascular distribution when it comes to toxoplasmic chorioretinitis. So the distribution would not be perivascular. What do we mean by perivascular? Surrounding the vessels. If the distribution is perivascular, it's CMV retinitis. Non-perivascular, then it's going to be called toxoplasmic chorioretinitis. That's how you differentiate between these two. And the syphilitic chorioretinitis, it is usually accompanied by meningitis that is caused by syphilis, that is syphilitic meningitis. So this patient most probably did not have any symptoms of meningitis. That's why we're gonna be able to rule syphilitic chorioretinitis really easily. So, a recap: CMV retinitis, the fundoscopic examination is going to show perivascular distribution with hemorrhagic lesions. HIV retinopathy, you are not going to get hemorrhagic lesions on fundoscopic examination, and the disease is going to be really mild with no floaters or blurred vision. Toxoplasmic chorioretinitis, same severity as CMV retinitis, but the difference would be non-vascular or non-perivascular distribution, and other than that the lesion is going to be similar. Syphilitic chorioretinitis has associated meningitis. That's how you're going to be able to differentiate between all of them. Retinitis pigmentosa is basically, it's a genetically inherited disease that starts to represent itself when the person is like above 10 years of age. And I had a friend whose cousin had this condition, and it's really easy for me to remember it because the first complaint that that kid started making was that he was unable to see in the night when it came to peripheral vision. His peripheral vision started getting bad in the night, and slowly and progressively as the years passed by, it got worse and worse and worse, to the point that he could not ambulate in the dark without someone's support. He needed to hold on to someone in order to uh, ambulate in the night. And that is how far I have actually witnessed the disease go. But as far as the books are concerned and the real world, where you see the patient long term, it gets progressively bad to the point that the night blindness then turns into day blindness as well. So the peripheral vision is initially affected, and it's usually presents at the night with night blindness. But as the time goes by, the peripheral vision starts narrowing down as well, until the central vision is also affected. So what's the reason behind starting at the periphery and ending up in the center? So initially the rods are affected, and since they play a vital role in the in vision at the night time, so you get affected. The night vision gets affected first, and when the disease progresses, the cones at the center of the retina, they also get involved, and once they get involved, the night blindness, in addition to the patient, also gets difficulty in seeing in daylight as well. So let's give it a read. Genetic mutation causing loss of photoreceptors, progressive retinal degeneration. Symptoms onset, as I told you, 10 through adulthood. Night blindness is the first symptom, and night blindness, that too more on the peripheral vision. Progressive visual field loss, mid periphery, decreased visual acuity, late finding. When the cone cells are affected, that is when the visual acuity is affected, so it's a late finding. Initially, night blindness with loss of peripheral vision due to the rods being affected, and late in the disease, cones are also affected. That results in decreased visual acuity and difficulties in vision in the daytime as well. Retinal vessel attenuation, optic disc pallor, abnormal retinal pigmentation. Why does retinal vessel attenuation occurs? Because of reduced metabolic demand of the retina. Since the retina starts degenerating, its requirement for metabolic requirement really decreases. So the vessels just get mm, disuse atrophy and they start becoming really thin, and the optic disc also becomes really thin due to all round degeneration of the structure. Legally blind by age 40. Now let's just skim through it. Photoreceptor degeneration in RP begins with rods which are located on the outer retina. That's why initial loss of peripheral vision. And they are responsible for vision in the dim lighting. That's why the night blindness in the therefore initial present typically night blindness and visual field effects, particularly in the mid periphery, increasing clumsiness. So if you ask the patient, how is the patient gonna say? The patient is gonna say, when it turns dark, I have a hard time seeing, especially in the periphery. So he's gonna be able to walk just fine as long as he is just looking forward. But when it comes to visualizing the structures on his left and on his right, he's gonna have trouble. So he'll be able to walk in a straight line, but when it comes to maneuver in the dark, he won't be able to do that. So that is how the patient says he's having trouble. So increasing clumsiness is common with progressive peripheral vision loss, and patients may notice photopsia adjacent to blind spots. In advanced disease, degeneration of cones occurs. Photoreceptors on the central retina responsible for vision in the bright light decrease to visual acuity. It results in the decreased visual acuity. Retinal vessel attenuation, decreased retinal metabolic demand. That's the reason. Pale optic disc due to nerve gliosis and atrophy. Pigment deposition in bone specule pattern. This is basically a late finding. The image here is showing the initial findings. You don't have any prominent bone specule pattern here going on. So it's just retinal vessel attenuation. As you can see, the vessels are like they're about to die. That is how thin they've gotten. And the optic disc, it's really pale. It should be bright yellow, but it's waxy and it's pale in nature, and you can see all around the retina looks like nothing's going on actually here except for degeneration. So here's a really good comparison of what a normal fundus looks like and what fundus looks like in advanced retinitis pigmentosa. As you can see, these bony, pigmentary bony spicules. This is what is happens in the late in the disease. That's what you can visualize. If you compare the vessels, you can really appreciate the narrowing and the attenuation of the vessels. So this is just an image to help you keep hold on to the facts of how the fundus looks like. Here is yet another image of the bony spicule pattern going on in the periphery and proceeding towards the center. As you can see, the vessels are also really thin and attenuated, and the optic disc looks like it's about to die just any minute now. So, uh, uh, the new research says that they have started using stem cell therapy in order to delay the progression of the disease. But here, the only information we have is omega-3 fatty acids that slow the disease progression. What is the treatment for retinitis pigmentosa? There's no known treatment. The only thing we can do is slow down the progression of the disease by using omega-3 fatty acids. And some trials are using stem cells in order to delay the progression of the disease, and the results are really good. But as far as STEP2 CK is concerned, omega-3 fatty acids to slow down the disease progression, there is no cure and there is no absolute treatment. So now we're gonna see all the reasons for acute painless vision loss. So the first one is central retinal artery occlusion. The second one, central retinal vein occlusion, artery or vein. Any of them gets occluded, we get painless vision loss. Retinal detachment, that is also painless. Vitreous hemorrhage, that is also painless. So there are a few key differences in all of these. We're gonna just go over them and we'll give a read afterwards. So, central retinal artery occlusion. This is like hyperacute because it's the artery. When you compare it to the central retinal vein occlusion, it can be acute or subacute in nature. But the retinal artery occlusion, it's totally acute. And usually it happens followed by few episodes of amaurosis fugax, which is actually painless temporary loss of vision due to episodic loss of blood flow in the central retinal artery occlusion. So if a person has a repeated history of temporary loss of unilateral, usually it's unilateral. It's not possible that the same eyes, both the eyes lose the vision at the same time. So usually it's unilateral and acute in nature, and it's painless. So if the patient has a history of temporary loss of unilateral loss of vision that is painless, and then it comes back, then most probably your diagnosis would be central retinal artery occlusion, because now the occlusion has become permanent. That's how the patient is not recovering his vision now. If you see the fundus, the highest yield point, pale fundus with a cherry red spot, that is how you know it's central retinal artery occlusion. First, with the history of temporary loss, unilateral loss of vision that is painless. Then the patient has like a permanent loss of vision that is painless. You most probably you'll be able to guess that it's most probably due to occlusion of the artery. So when it comes to central retinal vein occlusion, it's acute and subacute, not as quick as the artery one, but yeah, it's also painless in nature and it's also acute. So you if you see the fundus, you're gonna see the blood and thunder as we discussed. Central retinal artery occlusion, pale fundus with cherry red spot, central retinal vein occlusion, blood and thunder, acute and subacute in nature. Retinal detachment, I told you it's gonna progress with loss of peripheral vision first, and because of the debris in the vitreous, you're gonna see floaters. So that's what the patient is gonna complain. The patient is gonna say that he sees floaters during the detachment, photopsia, and starting with loss of peripheral vision, progressing slowly to the center as the retina slowly detaches from the periphery and progresses to the center. So, and the patient is also going to say he sees floaters because of the debris. Vitreous hemorrhage, both of them are connected. So what happens in vitreous hemorrhage? When the hemorrhage in the vitreous occurs, firstly the patient is going to see floaters and debris because of the RBCs floating in the vitreous humor. And other than that, because it's a hemorrhage, so once if you see the try to see the eye with an ophthalmoscope, usually the red reflex is really visible. Red reflex is basically shining of the retina when you see from an ophthalmoscope. But if there is vitreous hemorrhage and you cannot visualize the retina because of the RBCs and debris in the vitreous humor, so if you use an ophthalmoscope to visualize the fundus, you'll not be able to appreciate a red reflex. It's just gonna be absent due to the RBCs floating and obscuring the view of the fundus. So that's the summary for all of them. Now just also give it a read. Central retinal artery occlusion, severe vision loss with temporal sparing because of the cherry red spot in the center. Usually the center vision is usually affected more. History of amaurosis fugax, that's how you tie into the artery occlusion. So what is the treatment? uh, Possible intra-arterial thrombolytics, ocular massage, reduction of IOP, anterior chamber paracentesis. The most important one is just like if you get occlusion in your coronary arteries, if you get occlusion in your cerebral arteries, and you've confirmed that it's an occlusion, you give streptokinase, that is basically you try to dissolve the clot. Thrombolytics, fibrinolytics, that's the treatment. Possible intraarterial thrombolytics. CRVO, curvo, blood and thunder, no treatment, no absolute treatment, but if there's a lot of edema, you can use intravitreal VEGF, intravitreal anti-VEGF. Oh, so retinal detachment. What is retinopexy? We studied that as well. So vitreous hemorrhage. The main target in vitreous hemorrhage is to stop the bleed. So you're gonna use vitrectomy or photocoagulation in order to stop the bleed. It's not an emergency situation, but yeah, still. Uh, Also gonna blood and thunder, retinal detachment, grayish crinkled retina, vitreous hemorrhage, absent red reflex because of the RBC debris in the vitreous humor. RBC is floating in the debris in obscured view of fundus. The patient may also say that he sees floaters. You'll have to be able to make sense of all the symptoms. Obviously, it's the vitreous hemorrhage. The patient won't be able to see because his retina cannot perceive the light because of the RBCs, and the red reflex won't be appreciated. Now also give a read to vitreous hemorrhage. Vitreous hemorrhage often presents with sudden onset hazy vision or vision loss. Yeah, but it's painless. That's the main thing. Proliferative diabetic retinopathy is a common risk factor. Intravitreal vitreal blood prevents light from reaching the retina, causing patients to experience sudden onset hazy vision, sometimes with red hue or vision loss. The vision loss is not because of the eye not being competent. It's because the light is not reaching the retina. The patient is basically the light is not reaching the retina, and the patient cannot visualize anything because of that. Patient may also report seeing floaters or shadows due to floating blood clots. Yeah, I told you that. Examination finding depends on the density of the hemorrhage. Visualization of intravitreal red blood cells or debris on slip plan. 2. When the hemorrhage is dense enough, a dark red glow and loss of under details on ophthalmoscopy. Yeah, it's a variable presentation depending on the amount of hemorrhage. Cataracts. So what are cataracts? Cataracts is basically opacification of the lens, which can be age related. It is termed as senile cataracts, and it can be due to a disease process, like diabetes. It can be due to smoking, chronic sunlight exposure, and glucocorticoid use. Uh, Most commonly related to oxidative damage to the lens with aging. Other reasons: diabetes, smoking. Okay, cataracts are usually bilateral. But the thing is that it's not like the both the eyes are being affected at the same right. They are bilateral, but one eye is usually affected more than the other. So the patient complains of problems with the one eye more than the other one. Patients usually report painless blurring of vision, bothersome glare, and halos around the light. The halos around the light. This is like the highest yield point that I can say is about cataracts, halos around the light. This is what helps differentiate cataract from other disease processes which do not have halos. So initially, when the cataract is developing in the early stages, if you detect it at that time, the red reflex, which is basically the reflection of the retina, that's really fine, and you can also visualize the retina on retinoscope on ophthalmoscopy. But as the cataract becomes dense and it gets mature, it completely obstructs the view to the point that you cannot even visualize the retina and the fundus on the ophthalmoscope, and neither is the red reflex visible at that time. So most probably it was a question about cataracts, and one of the differentials was open angle glaucoma. What is the difference and how to differentiate that? Open angle glaucoma, it's also age related. So yeah, the patient would be old in both the cases, and the open glaucoma would initially lead to the progressive loss of peripheral vision, and on fundoscopic examination you would observe a cup to disc ratio of greater than zero point 0.6. Basically, cup would be bigger, and the disc would be of the same size. So this may lead to near miss motor vehicle collisions, but night driving is not preferentially affected because there is no problem in letting the light in towards the retina. But when it comes to cataract, it obscures the light from reaching the retina. That's why, and the and the ability to focus also gets bad. So that's why you get like glare, blurring of the vision, and halos because of the pacification of the lens. That's why you get halos. Does not cause halos. You know that I told you how important halos around the light was. So that is how you different got to be able to differentiate it. Does not cause halos around bright light. These are sometimes seen with acute angle closure glaucoma, but acute angle closure is really acute, so won't be able to. So you won't confuse it with cataracts. Uh, Treatment is indicated when loss of vision impairs activities of daily living. That's when cataracts are treated. When cataract is causing a lot of trouble. Other than that, they usually wait and watch policy, control your diabetes, try to quit smoking, try to limit the glucocorticoid use, and when the problem becomes really a lot, you can go for an intraocular lens procedure where you get a clear lens, where you get the cataract extracted and get the clear lens instead of it. So, ocular manifestations of HIV. So, HIV, CD count less than 100, you get CMV retinitis, uveitis, painful tearing photophobia. Yes, it's most probably anterior uveitis. So you're gonna have all the symptoms of anterior uveitis, like we discussed, a little bit of haziness on the cornea, a pus collection in the anterior chamber, hypopyon, and you're gonna get reduced visual acuity as well. Constricted hypopyon hyperemia due to intraocular HIV replication or secondary. Yeah, but it's anterior uveitis. It's just the same. It does not matter if it's because of HIV or it's because of ankylosing spondylitis or because of sarcoidosis or because of syphilis or because of anything else. It's going to be the same. So CMV retinitis, unilateral acute subacute loss of vision. Why? It's gonna be the same. The highest yield point about CMV retinitis was perivascular distribution of the lesions and hemorrhagic lesions also. Perivascular, and the lesions would be white fluffy with hemorrhages, but in a perivascular distribution. Cataracts, loss of, it's gonna be the same. Halos around the lights, progressive in nature, opacification of lens. Initially, no loss of red reflex. Afterwards, loss of red reflex. Surgery required if a lot of problem is being caused. Acute unilateral ocular redness, tearing, branching, dendritic. HSV keratitis, we studied that. Candida or fungal keratitis, also in AIDS patient. HSV keratitis, also in AIDS patient. HSV dendritic ulcer, candida or fungal keratitis, you're gonna get. What was it? It was like a irregular ulcer with feathered margin and satellite lesions. Neuroophthalmic complications, optic neuropathy, motor palsies. Yeah. So I've given you a lot of history about all of these. So yeah, I think that's more than enough. We've discussed everything that we discussed previously in this table as well. So photokeratitis. What is photokeratitis? Photokeratitis is inflammation of the cornea due to light. The name is more than suggestive of what it is. So what happens is usually if you get a really strong UV exposure for your eyes in places where the light is usually reflected, like while you're ice skating, the light just hits the ice, then goes into your eyes and it causes a lot of damage to the cornea. That is when you get photokeratitis. The main thing, the highest yield thing that you need to remember about photokeratitis is that it does not occur while the exposure happens. It's not like the person is skating in the ice and is like, oh, my eyes. It starts after you've done the activity. It starts 6 to 7 to 8 hours after that. So that is how you might confuse it with something else. The person went ice skating. The person had a really uh, hard. The person was in the desert, and the light just hit the sand and hit his eyes, and he had a really hard UV exposure. And after that, he came back home, and then the symptoms are going to start. What are the symptoms going to be? The patient won't be able to open his eyes due to pain. That's the biggest one. And since the light, it's not possible that the light only affects one eye. Obviously, it's going to affect both eyes. So it's usually and mostly In most of the cases, you just remember that it's bilateral. The patient won't be able to open his eyes due to irritation and pain, and the patient would be tearing as hell. A lot of tearing from the eyes, and if you try to open the eyes and you see it's they are gonna be red. And with the history, you're going to tie in everything and you're going to go for the diagnosis of photokeratitis. Let's give it a read. UV light causes desquamation of the corneal epithelium. How are you going to identify the desquamation? If you if you put the patient on a slit lamp and observe the cornea and put fluorescein dye on top of it, all the areas where the cornea has been, let me draw it for you and it's gonna become a little bit easy. So what actually happens is, like, this is the cornea. Usually if you put fluorescein, the fluorescein dye won't be adherent to the cornea, it's gonna just flow right down. But what happens in case of photokeratitis is that you get desquamation at irregular areas. And the cornea, if you see it microscopically, this is what the cornea now looks like after the outermost epithelium has been desquamated. It's been shed off, and the underlying basement membrane of the cornea is exposed. If you put fluorescein dye now, the fluorescein dye is not adherent to the epithelium, but now the epithelium has been shed off, and this area, the bumpy one, it's not epithelium, it's the basement membrane. So the fluorescein dye is usually really well adherent to the basement membrane. So in that case, the fluorescein dye just adheres to all the areas where the epithelium has been shed off to the basement membrane. So now when you visualize the cornea, you're gonna be able to visualize all the defects in the cornea, and that would be signaled by the areas where there has been uptake of the fluorescein dye. Those are all the areas where you know that the epithelium has been shed off and now the underlying basement membrane has been exposed. So that's how you confirm that the epithelium has been shed off, and this is a case of photokeratitis. So I've given you how the thing works and how to make sense of it. Now also we'll give it a read. Severe bilateral eye pain and photophobia 6 to 12 hours after exposure. Foreign body sensation. When I was in the eye department, he used to say all the patients that came in the eye department with a foreign body sensation, they used to I just want to mention it, they used to express it as ਅੱਖ 'ਚ ਰੜਕ ਪੈਂਦੀ ਏ ਅੱਖ 'ਚ ਬਹੁਤ ਰੜਕ ਪੈਂਦੀ ਏ ਤੇ ਇਹ ਰੜਕ ਵਾਲਾ ਲਫ਼ਜ਼ ਏ that's what they used to use. So yeah, it was really funny. I just wanted to mention it. ਅੱਖ 'ਚ ਰੜਕ ਪਏਗੀ, decreased vision, conjunctival erythema, chemosis tearing. Decreased vision, that's because the patient ain't opening his eyes. Punctate corneal staining with fluorescein dye. What does punctate means? Punctate means it's not gonna be uniform. It's gonna be like in the form of punches, because the desquamation is at random places, at random areas, and when you put the dye, it's gonna be adherent at random places, and in a punctate manner, like somebody has just poked holes in the cornea. Yeah, that's the word, poked holes in the cornea. The treatment is just supportive, and the symptoms would resolve as the corneal epithelium regenerates. So, what if they ask you what likely could have been done to prevent this? It would be UV protective eyewear. And if they ask what is the next best step in the treatment, that would be just give topical painkillers, topical antibiotics, rest. That's it. If you have supportive, that's going to be the answer. If you have rest, that's going to be the answer. If you have none of these and you have pain management, that's going to be the answer. And if they ask you what would could have been done, that's going to be UV protective eyewear. Now let's just give it a quick read before. Because of the reflection of the sunlight and sand on water, sand, snow, beachgoers and skiers are at the highest risk. You just need to remember this high yield patient population, beachgoers, skiers. These are the people who are at the highest risk. Photokeratitis usually represents 6 to 12 hours after UV. Bilateral eye pain and photophobia, gritty, radak pendi in the eyes, and visual acuity may be temporarily decreased. Examinations show staring with conjunctival injection and edema. The eyes are red. The patient ain't gonna open his eyes, but when he does, you see they are red as fuck. The presence of facial sunburn further supports the diagnosis of UV related. You have to tie in everything together. So yeah, it's a good indicator. The sunburn is also good indicator. Diagnosis is confirmed with fluorescein staining of the punctate defects on bilateral cornea. You're gonna be able to visualize this on the slit lamp. So that's how you confirm the diagnosis. Ocular trauma. So with ocular trauma, we're gonna do a little bit of discussion first. What is ocular trauma? Ocular trauma is anything that might lead to leaking of aqueous humor or destruction of the integrity of the eye. Open globe injury, blunt force trauma, penetrating trauma. So what are the few things that we need to keep in mind? So this is the cornea and this is the eye. So first of all, during open globe injury, what can happen? You can get a defect in the cornea. And if you get a defect in the cornea, it's going to be really easily visible. How? Since you have a defect in the cornea now, so if you put the patient in a slit lamp and put fluorescein drops on it, you're going to be able to easily visualize the leaking of the aqueous humor. So, since aqueous humor is transparent, it's really hard to make sense of whether it's leaking or not. But if you put fluorescent dyes on top of the cornea while visualizing the cornea and the eye under a slit lamp, the leaking would be really evident. And that leaking sign is termed as waterfall sign. So, waterfall sign is going to be the first indication of an open globe injury. The second indication of an open globe injury is going to be that if you see that the iris has a weird shape, has a weird shape, that represents that maybe a particle just went straight through the eye, sh- uh, uh, puncturing the cornea and then damaging the iris muscle. So basically, any discrepancy in the iris muscles is also in an indication of an open globe injury. I'll show you guys how it looks like in a second. So here is an example of damage to the iris muscle. So, eccentric or a teardrop shaped pupil, that means that the iris muscles have been torn or damaged. That is why you get a oddly shaped pupil. So, if you see a oddly shaped pupil, it's an open globe injury. And I've also explained a mechanism. Mechanism is that the cornea is punctured and then the iris muscles are torn by any particle or any debris that hits the eye. And relative afferent pupillary defect, you see the cursor. Why does this happen? A lot of reasons for this happening. The first one can be because of a blunt trauma. The eye socket moves as a whole and it tugs on the optic nerve, and since the optic nerve is a nerve, it's really sensitive, and if there's a really shearing force on it, the optic nerve might temporarily or permanently be damaged. So that's how you get a relative afferent pupillary defect, because the signals are not being carried as efficiently because of a damage to the optic nerve. The second reason why you might get a relative afferent pupillary defect, as I told you, the iris muscle might get damaged, and once they get damaged, you put in the light, you won't be able to observe the reflex as well, because the muscles are torn. They're not responding now, even though you might be getting the signal for the iris muscles to contract or dilate, but they're not responding. They're damaged. That's another reason as well. Decreased intraocular pressure. Why would you get a decreased intraocular pressure? That's really easy as well, because you're leaking aqueous humor. That's why. So, what's the management? Simple. You get an emergency ophthalmology consult. That's it. Because it's a emergency. So, anything in the answer, the only one you're gonna pick is emergency ophthalmology consult. That's it. Everything else it can cover. The CT scan of the eye, you can do it afterwards. The eye department is gonna handle anything that you need to do afterwards. Intravenous antibiotics, they're gonna take care of everything. So the answer that you pick once you detect an open globe injury is call the eye specialists. That's it. So I've explained all the clinical features with demonstration as well. It will be really easy for you to pick open globe injury. Now let's give a rapid read. OGL is typically caused by small high velocity particles, metal shards sent airborne by powerful tools, explosions, lawnmowers, motor vehicle accidents. Penetration of the globe most commonly occurs at the cornea. Large open globe injury may present with globe deformity. The large ones are really obvious. It's the minor ones that require a lot of expertise and a lot of skill to detect. The open ones, if the eye is just like this, you know it's an open globe injury. But if you don't have any obvious signs, that's when you need to make sure. Extrusion of vitreous or iris or a visible entry wound in the absence of obvious. We're talking about in the absence of an obvious wound. If it's obvious, you're gonna refer it to the eye department. They're gonna take care of it. But if it's not obvious, now make sure. OGL may be inferred by a peaked or teardrop pupil iris stretching due to laceration or a foreign body object that's in eccentric oddly shaped pupil, and because of the torn iris muscles, increased or decreased anterior chamber depth or reduced intraocular pressure. If the intraocular pressure is even less than the normal range, you know other potential manifestations include loss of visual, like absent afferent pupillary response due to tugging on the optic nerve, damage to the optic nerve, or damage to the iris muscles. OGL. If OGL is suspected but not obvious on examination, further assessment should be performed. The fluorescein drops as a aqueous drains through the puncture site. Fluorescein may be streaming away from the site, or clear fluid may be seen flowing through the fluorescein. This is termed as waterfall sign. Management of OGL requires shading of the eye and emergency ophthalmologic consult for surgical repair. Chronic complications, obviously, it's that is also easy because the eye integrity has been harmed. You permanent loss of vision, or if the bacteria gets in through the loopholes, you get an infection. Corneal epithelial defects, trauma or foreign body, contact lens use, exposure, everything. We'll just discuss it. UV exposure, that also causes corneal epithelial defects, as punctate fluorescein uptake would be observed, because like it's like defect occurs as in like someone just poked holes in the cornea. If you wear contact lens, abrasion can occur. Open globe injury, that's corneal epithelial defects can also occur. So severe eye pain, foreign body sensation, radak pendi, increased staring, photophobia, reluctance to open eye. It's not that. It's really basic. Pen light test, assess pupillary shape, function, and inspect a foreign body. Visual acuity, fluorescein evaluation. Fluorescein examination after above test. Concentrated uptake indicates corneal epithelial defect. So if you have a corneal laceration, just be sure that the epithelium is not present. So fluorescein is gonna be adherent to the basement membrane. So you can also visualize the depth of the uh, uh, depth of the lesion. You can also visualize the shape of the lesion. You can also visualize the location of the lesion on the cornea. So that's really easy. And we just discussed anything that causes abrasion on the cornea that can lead to corneal epithelial defects. The UV light can cause desquamation. Contact lens use can cause uh, lacerations or abrasion basically. And if your eyelid is just really rough on the cornea, that can incomplete lid closure, that can also, if you rub anything against, that can also cause. And what happens when the cornea is desquamated? The eyes become really sensitive, they start tearing up, they start getting red, and it's a discomfort. uh, because of higher velocity of injury mechanism, there is also risk for open globe injury. However, there is no obvious signs of OGI, visible entry wound, globe deformity, irregular shape pupil. In the absence of obvious open globe injury, what are you going to do? You're going to make sure it's not an open globe injury. So you're going to resort to fluorescein examination and slit lamp. If that's clear, then you can rest assured that it's not an OGI. Further corneal assessment should be performed via fluorescein staining. So, what happens? A patient comes with a suspected OGI. You see the pupil, if its shape is normal or not. You see if there's a visible entry wound or not. You see if there's a visible globe deformity or not. Once you're done with that, you use the slit lamp and fluorescein dye to make sure you don't see a waterfall sign and you don't see the uptake. And if there's epithelial, if it's just epithelial problem, that would also be detected. So the fluorescein staining under the slit lamp makes sure it's not a OGI, and if it's just epithelial desquamation, it's going to also tell you about that. A discrete area of adherent fluorescein is typical of corneal abrasion. In contrast, concentrated uptake of fluorescein with subsequent clearing in a waterfall pattern indicates full thickness corneal laceration with an OGI. The cornea has been ruptured and the fluid is leaking out. It's going to differentiate between abrasion and a laceration. That's what the fluorescein staining under a slit lamp does. Fluorescein clearing in waterfall pattern should wash out from. What are you going to do if you see this? Ophthalmology consult. So, what is the management of a corneal abrasion? If you suspected an OGI, you did fluorescein staining and you saw it under slit lamp, then you did not see a waterfall pattern. You saw a uptake, just an uptake, no waterfall pattern. So you knew it was an abrasion. What are you gonna do next? You're gonna make sure that there is no foreign body in the eyes. You're gonna make sure that there is no ulcer, everything that you're gonna make sure it's not an open globe injury, and remove any foreign body if it is present. So now you're gonna try to find the reason behind the abrasion. If it was contact lens use, then what are you gonna do? You're gonna do fluoroquinolone drops. That's what fluoroquinolone drops or anti-pseudomyl drops. It's the same thing. You can use tobramycin, ciprofloxacin. It's just a fluoroquinolone. One the high yield thing about this is your contact lens wearer fluoroquinolone drops. If it's traumatic in nature, like patient just rubbed his eyes or something, just rubbed the eyes and cornea got desquamated, then what are you gonna do? You're gonna use the antibiotics that we use for normal bacterial conjunctivitis. For bacterial conjunctivitis, due to contact lens, fluoroquinolone drops. Bacterial conjunctivitis due to another reason, tobramycin, erythromycin ointment or polymyxin or trimethoprim ointment. That is what you're gonna give in these cases. So it's really easy when it comes to choosing antibiotics. If it's a contact lens wearer, fluoroquinolone drops. Other reason, erythromycin ointment or polymyxin trimethoprim ointment. It's the same case for corneal abrasion as well. And what are you going to do? So what usually happens if the etiology is a contact lens wearer, so you're gonna do a follow-up 24 hours after just to make sure that the infection is not continuing. Other than that, if it's because of something sharing or traumatic in nature, you're not gonna do a follow-up unless it's more than 3 millimeter. So here it's written like it's also if it's less than 3, you don't do a follow. More than 3, yes, you can. But if it's a contact lens is the culprit, you do a follow up 24 hours just to make sure that the infection is not progressing any further. Corneal abrasion, a defect in corneal epithelium that usually results from minor trauma in contact lens user. Corneal abrasion is typically caused by overworn, improperly fitted, or contaminated lenses. In addition to experiencing pain, tearing, photophobia, patients also have a Ruddock pandia foreign body sensation in the eyes. The diagnosis confirmed with fluorescein staining, which tells you the area, location, size, shape of the uh, corneal defect. Fluorescein stains, yeah, here's the reason. Fluorescein stains corneal basement membrane but not intact corneal epithelium. Therefore, if a corneal epithelial defect abrasion is present, its shape, size, location can be diagnosed by a demarcated area of fluorescein uptake. I drew the diagram, explained you the mechanism.